Welcome back to the deep dive, everyone. This is where we, really try to cut through all the noise and
We're
complexity.
getting right to the heart of it.
Exactly. We want to distill things down so you can genuinely master the topic. Today, we're tackling something super common, but surprisingly tricky. Chest pain.
It really is. It's one of those symptoms that can mean almost anything, from completely benign to, well, life-threatening.
Right. And figuring that out, that diagnostic maze, it takes more than just book smarts, doesn't it? It's almost an art form.
It definitely involves clinical artistry, yes. Synthesizing all the pieces.
So our focus today is a specific case, a really insightful one. We've got a 67-year-old man who comes in with chest pain. But we're not just going to, glance at his chart. No way. For you listening, our mission is much bigger than that.
We're aiming for real understanding.
Totally.
Yeah.
Today, we're not just reading a case. We're dissecting it, piece by piece. We want you to master why every single diagnostic choice matters. What makes one step right and another, well, potentially dangerous.
And those subtle differences between conditions that look similar on the surface, they're crucial.
Crucial.
Yeah.
And importantly, how to spot and steer clear of those common traps, those cognitive pitfalls.
Yeah.
The kind of things that pop up on exams or even in real practice.
The MCQ traps.
Yeah, exactly. This isn't about just getting the answer. It's about understanding the whole journey to that answer deeply and confidently. So consider yourselves deputized. Time to be medical detectives.
I like that.
We've got our patient, we've got a puzzle, and a whole bunch of potential paths forward. Let's unpack this thing.
Absolutely. And what's really fascinating about this case, I think, is how these seemingly tiny details, something in the history, maybe a nuance in the physical exam, can just completely shift your thinking.
Right, like a hinge point.
Precisely. It changes the whole diagnostic approach and definitely the choice of the most appropriate next step. It's all about pulling those fragments together, this case. It's a masterclass in applying that foundational knowledge to a really nuanced real-world situation. Shows how every bit of info counts.
Couldn't agree more. So let's lay out the initial evidence. Let's meet our patient and start gathering clues. We have a 67-year-old male.
Okay.
Straight away, that age 67 that immediately flags him, doesn't it? Higher risk for cardiovascular disease.
Definitely. For men, risk really climbs after 45. So 67 puts him squarely in that higher risk category. It's a non-modifiable factor, but a really significant one.
It's like finding someone in the right age bracket at a crime scene. Doesn't prove anything yet, but it focuses your attention.
Exactly. That 67 years is kind of a silent alarm bell. It means we just cannot take chest pain lightly in this demographic, even before we hear anything else.
So his pretest probability for something like CAD, it's already nudged up a bit.
It absolutely is, right from the start. It
Yeah.
tells us, be vigilant.
Okay. And his chief complaint, chest pain. He says he's been having it for about 2 months.
2 months. Okay.
Now, that duration, 2 months, that's a really key piece of information, isn't it? It immediately starts to frame the problem differently for us.
It's vital, yes. A 2-month history. It instantly helps us differentiate this from, say, an acute coronary syndrome, an ACS.
Right. ACS is usually sudden or getting worse fast.
Exactly. New onset or acutely worsening pain, usually over hours or maybe days. This chronicity, this longer timeline, it points our thinking towards more stable chronic conditions, not an immediate unfolding emergency. We're looking for a pattern here.
So let's dig into the characteristics of this pain.
Mm-hmm.
This is where the picture really starts taking shape. She says it's episodic, comes and goes, not constant.
Mm-hmm.
And when it does happen, it lasts maybe 5 to 10 minutes, then goes away on its own, spontaneously subsides.
Okay.
That whole cluster, episodic, short duration, self-resolving, that's pretty telling, wouldn't you say?
Oh, absolutely paramount. That cluster of descriptors, it's almost textbook for angina pectoris, specifically stable angina.
Stable angina.
Yes. The episodic nature, the short duration, the spontaneous resolutions, these are classic signs of transient myocardial ischemia. Think of the heart needing more oxygen, maybe during stress.
Like hitting the gas pedal.
Exactly. Hitting the gas. Heart rate, blood pressure go up, demands more oxygen. If the fuel lines in the coronary arteries are narrowed by plaque, they can't quite keep up. The engine sputters, metaphorically speaking. That's the pain.
But it's temporary.
Crucially, temporary. As soon as the demand drops, you take your foot off the gas, the heart recovers. No permanent damage. That's fundamentally different from a heart attack, an MI, where tissue is actively dying.
Gotcha. He says the pain is on the left side of his chest, but it doesn't radiate anywhere.
Okay, left-sided, non-radiating.
Now, left-sided pain, that makes you think heart straight away, but non-radiating. Maybe that sounds a bit reassuring. Can we be misled by that?
We absolutely cannot let that mislead us. Yes, classic cardiac pain often radiates left arm, jaw, back. But its absence doesn't rule out a cardiac cause at all.
So some people just feel it in one spot.
Some patients with definite ischemia just experience localized discomfort. It doesn't spread. So we note it, it's part of the picture, but we don't let it outweigh the other features, the episodic nature, the duration, if they're strongly pointing towards the heart. It's a nuance, not an all clear.
Okay, now this next detail, for me, this really started pulling things together. He says the pain typically occurs when he is angry or upset.
The trigger.
How significant is that emotional trigger?
That is a huge clue, a direct link to stress, both emotional and the physiological response it causes.
Fight or flight.
Exactly. Anger, being upset, that triggers the sympathetic nervous system. Heart rate climbs, blood pressure goes up. For a heart with underlying CAD, where blood flow might already be tight,
That extra demand is too much.
it easily tips the balance into ischemia, causing that anginal pain he describes. It's not just suggestive of stable angina pectoris, it's practically a hallmark feature, stress-induced angina.
And adding to that stable picture, he says there haven't been any changes. No change in the pattern, the intensity, or how long it lasts over these whole 2 months.
Right. Consistent.
That consistency, no crescendo pattern, that's our big signal. This isn't something acute blowing up right now, right?
That's exactly right. That unwavering consistency over 2 months is a very strong indicator of stability. If he'd said, it's happening more often now, or it's worse, or it's starting to happen when I'm just sitting, that would be alarming.
Unstable angina, maybe?
Precisely. That would suggest unstable angina or even an evolving ACS, and we'd need a much more urgent workup. But the absence of that crescendo pattern, it really reinforces our working hypothesis of stable CAD.
He also says no other symptoms come with it. No shortness of breath, no sweating, no nausea.
Okay, no associated symptom.
What does that tell us? Or maybe what doesn't it tell us?
Well, the absence of those sort of classic associated symptoms, dyspnea, diaphoresis, nausea, it does further support the idea this isn't an acute, severe event like a heart attack.
Makes ACS less likely.
Much less likely, especially combined with the stable pain pattern. Now, we do have to remember some patients, maybe women, diabetics, older folks, they can have atypical presentations or just these associated symptoms without typical chest pain.
Anginal equivalent.
Exactly, anginal equivalents. But here, the complete lack of these secondary symptoms, coupled with everything else, it strongly points away from ACS and helps triangulate towards stability.
Okay, let's pivot to his past medical history. This is crucial. First up, he has a history of asthma.
Okay.
Asthma. Now, listeners, this isn't just a side note. Pay attention here. This is going to be a huge factor, a real differentiator when we talk about testing later. Keep that asthma in mind.
Indeed. That asthma diagnosis, it might seem totally unrelated to chest pain at first glance, right?
Yeah.
But it becomes absolutely critical, a deciding factor in picking the most appropriate diagnostic test down the line. It's a perfect example of how comorbidities other existing conditions have to shape our specific management plan, not just the general idea.
It's about tailoring the approach.
Precisely. It's a key piece of his specific story.
Okay, what else? He also has hypertension, high blood pressure.
Right. Another big one.
And we know that's a major cardiovascular risk factor, isn't it? Bumps up his chances of having coronary artery disease quite a bit.
Absolutely. Hypertension is a well-established independent risk factor for atherosclerosis, for CAD. It just relentlessly damages arteries over time, makes them stiffer, narrower.
So his age, 67, plus hypertension.
It significantly amplifies our concern for underlying CAD. It pushes his pretest probability even higher, another heavy weight on that side of the scale.
Got it. Now, medications. He's taking albuterol.
For the asthma.
Makes sense.
And amlodipine.
For the hypertension. Okay.
So the meds line up perfectly with his history. No surprises there.
Correct. They basically confirm the diagnoses we just discussed and, importantly, remind us his asthma is an active issue he's managing, not just something from childhood.
Good point. How about lifestyle? He swims once a week, tries to eat healthy.
Okay, some positive efforts, which is good, right. But does it really cancel out the age and hypertension?
Not really, no. It's definitely positive, shows he's engaged. But those efforts don't erase the impact of significant long-standing risk factors like age and hypertension, or the very concerning symptoms he's describing.
It's a mixed bag, risk-wise.
It is. It provides a more complete picture, but the scales are still tipped towards significant risk here. He also drinks a couple glasses of wine on weekends, moderate, not a big worry, and thankfully no smoking or illicit drugs.
That's a definite plus. Avoid some common big risks.
Huge plus, yes. Takes those off the table.
Okay, let's move to the physical exam and vitals.
Hmm.
Are there any immediate alarm bells here? Or do they fit with this stable angina idea?
Let's see.
Temperature, 37.0 Celsius, 98.6 Fahrenheit. Normal.
Good, no fever.
Pulse, 88 per minute, a little up.
Slightly elevated, yeah, but not drastically so. Could easily be because he's feeling upset, which he said triggers his pain, or just, anxious being evaluated. Not acutely alarming in itself.
Respirations, 12 per minute. Normal.
Normal respiratory rate.
Good. Blood pressure, 130/88.
Okay, 130/080. So presumably that's on the amlodipine. It suggests his hypertension is, well, reasonably controlled, but
It's still a bit high.
it's still on the higher side of optimal, yeah. Not stage 2 or anything crisis level, but that chronic, subtly elevated pressure still adds to the arterial wear and tear over time. It keeps nudging up his baseline risk.
So control doesn't mean zero impact.
Exactly. It's a reminder of that. But overall, the vitals are largely reassuring in the acute sense. No signs of immediate decompensation. We can take a small breath.
Okay, cardiac exam, point of maximal impulse, the PMI, is in the normal spot. Fifth intercostal space, mid-clavicular line.
Normal location.
And listening to the heart. No murmurs, no rubs, no gallops.
All normal findings. That's really important. It helps rule out other serious things that cause chest pain, like acute valve problems or pericarditis causing a rub or heart failure causing a gallop.
But crucial.
But, and this is absolutely key, these normal findings do not rule out stable CAD. The heart can sound perfectly normal between anginal episodes, even with significant blockages, as long as there isn't major structural damage or valve disease making noise.
Right. And finally, his ECG. It shows sinus rhythm, no abnormalities.
Normal ECG at rest.
Another critical finding, right? Rules out the big, scary, immediate stuff like a STEMI, a major heart attack showing up electrically.
Absolutely. It gives us vital reassurance he's not having a massive acute event right now. His heart muscle isn't showing signs of major injury at this moment.
But, and this is where people get tripped up, isn't it? A normal resting ECG tells us almost nothing about whether he has stable CAD that causes symptoms under stress.
Precisely. That's a huge potential pitfall. A normal ECG in someone with chest pain does not equal a clean bill of health for the coronary arteries. Stable angina is, by definition, transient ischemia. It often resolves before the ECG is even done, or it might only show changes during the stress that causes it.
Like the check engine light being off when the car's idling, but it flicks on when you floor it uphill.
That's a perfect analogy. The resting ECG tells you about the acute situation right now, but not necessarily about the underlying chronic problem waiting for a trigger.
Okay. So let's synthesize. We've gathered all these clues. What's our initial assessment? Age 67, hypertension, these very typical stress-induced, stable chest pain episodes, even with the reassuring exam and ECG.
Yeah.
What does it all add up to?
It all points quite strongly towards an intermediate to high pretest probability PTP of coronary artery disease, CAD.
Intermediate to high. Okay.
Meaning, based on everything we know before doing specific diagnostic tests, the likelihood he has significant CAD is substantial. We simply cannot ignore these symptoms or write them off.
We have to investigate further.
We absolutely have to pursue further, more definitive evaluation. This is where clinical judgment meets the evidence.
Which brings us right to the core question of this deep dive. The central puzzle. Given everything we've just laid out, all these clues, what is the most appropriate next step to evaluate for coronary artery disease in this specific patient? This is the crossroads. Which path do we take?
And that question really forces us to think critically. In someone like this intermediate to high risk, stable symptoms, normal baseline test, what's the optimal way forward? We need to confirm or rule out significant disease, but we have to do it thoughtfully.
Considering everything about him.
Exactly. It brings up the need to really understand the tests, what they're for, when they're indicated, and crucially, when they're contraindicated. We need the right test for this individual.
Okay, let's dive deep into the options. We'll scrutinize each one, starting with the ones that might seem okay at first glance, but really aren't the best choice here.
That's good.
First up, option A, no further testing at this visit. Now, interestingly, about 15% of people pick this in similar scenarios, but it's wrong. Expert, why is stopping here a mistake for this patient?
The fundamental flaw, as we've really been building up to, comes back to his pretest probability. We've established he has an intermediate to high PPP of CAD.
Not low risk.
Definitely not low risk. And that distinction is absolutely critical. It immediately makes no further testing an inappropriate and, frankly, potentially unsafe choice.
But couldn't we argue he feels okay now, the tests were normal? Maybe testing just causes anxiety or false positives? Where's that line?
That's a really important point, and it touches on a common clinical reasoning trap. The idea of avoiding overtesting is valid, but only when the pretest probability is genuinely low.
Ah, okay, so that rule applies to low-risk people.
Precisely. Deferring a CAD workup and maybe looking for other causes of chest pain first. That's reasonable if the patient has a low PTP. In those folks, yes, further testing might lead to false positives, anxiety, maybe unnecessary procedures.
But that logic just doesn't fit our guy.
It absolutely does not apply here. His symptoms, his age, his hypertension, they firmly place him outside that low PTP group. Sending him home without further evaluation would be a serious clinical error. We'd be ignoring strong clues, missing a potentially significant treatable condition.
It's misapplying a good principle to the wrong situation.
Exactly. That's a classic MCQ trap, too, taking a rule like avoid overtesting in low risk and applying it where it doesn't belong. Always, always assess the PTP first.
So, lesson learned. If no further testing is an option, first question is, what's the PTP? Here, it's not low, so we must test further. Responsible, evidence-based care.
Correct.
Okay, so if just watching isn't right, maybe we need biomarkers. You hear chest pain, especially in a 67-year-old, and heart attack flashes in your mind, right? It makes you think, troponin.
It's a common reflex.
Option B, troponin T measurement. Only 3% chose this, interestingly. Also incorrect. Why isn't troponin the answer here?
It comes down to understanding the specific job of the troponin test. Troponin levels like troponin T are measured primarily, almost exclusively, for working up a suspected acute coronary syndrome, ACS.
Like NSTEMI or STEMI, active heart attacks.
Exactly. Situations where there's acute myocardial damage happening, heart muscle cells are dying and leaking these proteins into the blood, that's when troponin levels go up.
And we've already pretty much decided ACS is unlikely here, based on his story.
You have. ACS is extremely unlikely for all the reasons we discussed. No acute chest pain. It's chronic, episodic, resolves on its own. And no acute ECG changes. No ST elevation, new LBBB, significant depressions, etc. His ECG was normal.
His presentation is classic stable CAD, not acute.
Correct. It's a chronic condition pattern, not an acute evolving MI. The pain is triggered, lasts minutes, goes away. That's the opposite of an acute event causing ongoing damage and troponin release. So in this stable CAD picture, measuring troponin T has very little diagnostic value.
A normal troponin wouldn't rule out his stable CAD.
Not at all. And an elevated troponin would be completely unexpected given his stable story, potentially sending everyone down the wrong path, maybe leading to unnecessary aggressive acute treatments. It's a red herring in this context.
So this really highlights that crucial difference, acute coronary syndrome versus stable angina. Troponin for ACS, but not the right tool for stable CAD evaluation.
Precisely. It's a key differential. An exam question might dangle troponin because chest pain will talk heart attack, but you have to look at the details, the pain characteristics, the ECG. They tell the real story. Relying on just chest pain leads you astray.
Got it. Okay, let's move to option C, adenosine myocardial perfusion imaging. 5% chose this one, also incorrect. And this brings us right back to that detail we flagged earlier, his asthma.
Bingo. This is exactly where that piece of history becomes the absolute deciding factor.
Okay, explain the connection. How does adenosine imaging work, and why is asthma a problem?
So adenosine myocardial perfusion imaging uses a pharmacological stress agent like adenosine or another one called dipyridamole. These drugs are powerful vasodilators.
They open up blood vessels.
They open up blood vessels. Now, in a healthy heart, they widen all the coronary arteries, boosting blood flow everywhere. But if you have a significantly narrowed artery due to plaque, that diseased vessel is often already dilated as much as it can be, just trying to get enough blood through.
It's maxed out.
It's maxed out.
Yeah.
So when you give adenosine, it dramatically widens the healthy arteries, but can't widen the diseased one much more. What happens? Blood flow preferentially rushes down the wide-open healthy vessels, effectively stealing blood away from the area supplied by the narrowed artery.
Ah, the coronary steal phenomenon.
Exactly. That steal creates a temporary controlled oxygen deficit ischemia in that area, which we can then detect with the imaging part of the test. It mimics exercise-induced ischemia.
Clever mechanism. But there's a big catch for our patient.
A huge, potentially dangerous catch. Stress testing using adenosine or dipyridamole is absolutely contraindicated in patients with reactive airway disease, like asthma, because these specific agents can trigger severe bronchospasm. They can cause the airways to constrict suddenly. Imagine causing an acute asthma attack While you're already stressing the patient's heart, that's a serious medical emergency. It's not just a theoretical risk, it's a known dangerous side effect in these patients.
And our patient definitely has asthma, uses albuterol.
Unequivocally. His history of asthma and his use of albuterol clearly mark him as having reactive airway disease. So, using adenosine or dipyridamole would be unsafe and inappropriate. That detail in his PMH is a hard stop for this testing option.
Okay, so if someone did need a pharmacological stress test, maybe because they couldn't exercise but they also had asthma, what would be the alternative?
Good question. If pharmacological stress was necessary for an asthma patient, the appropriate agent would be dobutamine.
Dobutamine, how does that work?
Dobutamine works differently. It's a beta agonist. It increases heart rate and contractility, basically making the heart work harder, mimicking the effects of exercise on oxygen demand. Crucially, it does not cause bronchospasm, so it's generally safe for patients with reactive airway disease. Same goal, stress the heart, but a different, safer mechanism for them.
This is such a critical point. It really tests if you know the specific contraindications based on comorbidities. You have to connect the asthma and the albuterol directly to why adenosine is wrong.
Absolutely. It's not just about knowing a stress test exists, it's knowing which stress test is safe and appropriate for this patient. Don't just pick one without checking those contraindications. Patient safety first.
Imagine giving someone with asthma something that could cause an attack just to test their heart. That's why these details are vital. It's personalized medicine in action.
Precisely. It underscores that we treat individuals, not just symptoms or test results in isolation.
Okay, let's look at option D, coronary artery calcium seam scoring. Only 6% chose this, also incorrect for this patient's next step. Expert, CAC scoring is used a lot in cardiology now. Why isn't it right here?
CAC scoring is definitely a valuable tool, but its value is quite specific, and that's the key. Its primary role is for risk stratification.
Assessing future risk.
Exactly. Especially in patients who are asymptomatic but have some risk factors, or maybe those with a low pretest probability of CAD where you want to refine their risk estimate.
How does it work?
It's a non-contrast CT scan that looks for and quantifies calcium deposits in the walls of the coronary arteries. Calcium is a marker for atherosclerosis for plaque buildup. So a higher PAC score means more plaque, more atherosclerosis, and therefore a higher future risk of heart events.
Okay, so it tells you about the presence of disease, the plaque burden. But our patient isn't low PTP, and he's actively having symptoms.
Precisely the point. Our patient has an intermediate to high PTP and is symptomatic with classic anginal features. For him, we need more than just knowing if plaque is present. We need to know if that plaque is actually causing his current symptoms by limiting blood flow under stress. Is it functionally significant?
Is it causing the ischemia?
Yes. CAC scoring confirms the presence of atherosclerosis, but it doesn't tell us about its functional impact. It doesn't tell us if that specific plaque is the reason he gets chest pain when he's upset. It's a static snapshot of plaque burden, not a dynamic assessment of blood flow during stress.
So back to the car analogy. It tells you there's rust on the engine parts, but not if the engine is actually misfiring when you accelerate.
Perfect analogy. For our symptomatic patient with a higher PTP, CAC scoring isn't the right initial diagnostic step. We need a test that directly evaluates for stress-induced ischemia, or perhaps looks closely at the anatomy for significant blockages that could cause ischemia. While a high CAC score would confirm he has atherosclerosis, it doesn't answer the immediate question. Is this chest pain ischemic?
So it highlights knowing the role of each test. CAC for risk stratification, especially in lower risk or asymptomatic folks. But for higher risk, symptomatic patients like ours, you need something more functional or detailed anatomically.
Exactly. It helps us choose the right tool for the specific clinical question we're trying to answer, avoiding both under-investigation and inappropriate testing. We need to know why he's having symptoms now.
Okay, which brings us, finally, to the option that elegantly ties everything together. Option E, exercise ECG test. The majority, 70%, chose this. And it is, indeed, the correct answer.
Yes, this is the one.
Let's break down exactly why this is the most appropriate next step. Why is this smart clinical decision-making for this patient?
This choice really is a beautiful illustration of personalized medicine. We're not just picking any stress test. We're carefully selecting the safest and most informative one for this specific individual, considering all those nuances we discussed.
So what's the general guideline for someone like him? Stable chest pain, intermediate to high risk. what should happen?
The guidelines generally recommend that these patients undergo either coronary CT angiography, CCTA, which gives detailed anatomical pictures of the arteries, or cardiac stress testing, CST, to further stratify their risk and guide treatment.
CCTA or stress testing? And what's the goal of the stress testing part?
The goal of any cardiac stress test is to look for stress-induced ischemic changes, evidence that the heart isn't getting enough oxygen when put under demand.
And how do we see those changes?
We can see them either on the ECG, which is what happens in an exercise ECG test, or through cardiac imaging done during or after stress, like stress echo, stress MPI, like the adenosine test, or stress MRI. The idea is to safely reproduce the conditions that might be causing his symptoms.
And how do we create that stress? We talked about drugs.
Right. Stress can be created pharmacologically using drugs like dobutamine to speed up the heart, or vasodilators like adenosine to cause steel, or it can be created through physiological stress, actual exercise.
Like walking on a treadmill.
Exactly. Treadmill or stationary bike. This increases heart rate and contractility naturally, boosting the heart's oxygen demand, just like real-life exertion does.
Okay, now connect all that back to our patient. Why is the exercise ECG test the winner for him?
All right, let's put the pieces together. 1, he fits the criteria perfectly stable chest pain, intermediate to high PTP. We need to check for ischemia. 2, we established his asthma as a clear contraindication to using adenosine or dipyridamole for pharmacological stress. That rules those out.
So drug options like adenosine MPI are off the table. What about dobutamine stress echo?
Dobutamine stress echo could be an option, as dobutamine is safe with asthma. However, the simplest, most physiological, and often first-line approach, if the patient can exercise, is the exercise ECG test.
And can our patient exercise?
Yes, he swims weekly, suggesting he's ambulatory and capable of exercise. Crucially, exercise itself is not contraindicated by asthma. So an exercise ECG test provides that necessary physiological stress to check for ischemia without the respiratory risks of adenosine and dipyridamole. It's effective and safe for him.
It's the most direct and safest route given his specific situation.
Exactly. It's often more readily available and less expensive than imaging stress tests, too. It directly assesses how his heart's electrical activity responds to demand and whether it reproduces his symptoms.
So what will this test actually tell us? How does it move things forward?
It provides critical, actionable information. If his ECG shows significant changes, like ST segment depression during exercise, or if his typical chest pain is reproduced at a certain workload, that strongly suggests significant CAD is causing ischemia.
And that guides treatment.
Directly. It helps confirm the diagnosis, gives an idea of his functional capacity, helps assess his prognosis, and informs treatment decisions like starting or adjusting anti-anginal meds, pushing harder on lifestyle changes, or even deciding if he needs a coronary angiogram to look directly at the arteries if the ischemia seems significant. It's a key step.
It really feels like the right answer because it required integrating everything, symptoms, risks, ECG, and the asthma contraindication.
Yeah.
It's the most appropriate because it's effective A&D, safe for this specific guy.
That's the essence of it. It's a masterful clinical choice because it synthesizes all the data points into the single best path forward for this individual. That's the art and science combined.
All right, let's consolidate this. Key takeaways for everyone listening, trying to master this. What have we really learned from this deep dive?
Okay, first big takeaway. The absolute need for a holistic patient assessment. It's not just checking boxes. Every detail matters. That asthma history wasn't random. It was a critical pivot point. You have to see how all the pieces connect for that patient.
Right. And second, really understanding how to differentiate clinical presentations. Acute coronary syndrome versus stable angina. They look different, need different initial tests, troponin versus stress testing. Getting that distinction right based on pain characteristics and ECG is fundamental. Avoids major errors.
Absolutely. Third, in this case, hammered at home. Understanding test indications, A&D contraindications. Knowing when to use a test is only half the battle. Knowing when not to use it because of patient factors, like asthma-blocking adenosine use, is just as vital for safety and appropriateness. That's nuanced, expert-level thinking.
Couldn't agree more. Fourth, the power of pretest probability, we keep coming back to it, is the patient low risk, intermediate, high. That initial assessment guides everything, preventing both overtesting the low risk and undertesting the high risk. Always start there.
And finally, the concept that we're looking for the most appropriate next step, not just a possible step. Several tests might seem plausible, but only one truly fits best when you consider effectiveness, safety, patient specifics, maybe even cost or availability. It's about finding that just right test for the individual.
Fantastic summary. So you listening haven't just learned what the right answer is, but you've dissected why it's right, and maybe more importantly, why the other options, even the plausible ones, fall short. That's the path to true mastery, going beyond the fact to the reasoning.
That's the goal, deeper understanding.
So we've tracked this journey from chest pain through history, exam, weighing options, hitting contraindications, and landing on the exercise ECG. It's about treating the whole patient, their unique landscape.
It really shows medicine as this blend of science, integration, and critical thought.
Absolutely. So here's something to think about after this deep dive. What really stands out to you? Next time you encounter chest pain, think beyond just the symptom. Which test truly fits every single piece of that unique patient's story? How would just one change? No asthma? Maybe pain only with heavy lifting? Maybe subtle ECG changes? How would that ripple through and potentially change the entire diagnostic plan?
That's a great question to ponder.
Being able to run those mental simulations to pivot your thinking based on changing details, that's when you know you're really getting it.
That's clinical reasoning.
Thank you all for joining us for this deep dive into cardiovascular diagnostics. Keep digging deeper, keep asking why, and we'll see you next time on The Deep Dive.